So we know that life is an age-related neurodegenerative disease. So after about 35, we all start losing brain volume. And given sufficient time, everybody will become cognitively impaired and their nervous systems will fail. From an evolutionary perspective, we weren't designed. There wasn't a natural selection beyond the mid-30s, because by then we were completed reproduction. It's only quite recently that the behavioral psychologists have said, well, actually there is a role for older people in society, but that's a social evolution. At a biological evolutionary perspective, we never evolved to live past mid-30s. And so our aging is there for a reason, I suspect, from a biological perspective, but it pans out in MS as well. We know that in multiple sclerosis now, some recent data has shown that people who are older have much larger brain volume losses than people that are younger for the same disease duration. So MS interacts with aging mechanisms. And so we have to then think about what happens as you get older that we can optimize to improve MS outcomes. And one of them is comorbidities. So there's a study done in Canada by Ruth Ann Murray where she looked at vascular comorbidities and just divided up people with MS into those that had or didn't. And that was smoking, hypertension, diabetes, or hypercholesterolemia. And if you had any of those comorbidities, your progression rate in terms of disability was much, much higher than if you didn't have them. Time to walking stick was 6 times quicker if you had a comorbidity. So you got there to a walking stick at 11 years on average versus 18 if you didn't. Which means we have to then start thinking about improving the overall health and wellness of a patient. And that may underlie the hypothesis that high-dose simvastatin, which reduces cholesterol, seems to be effective in multiple sclerosis. So a trial in secondary progressive MS with high-dose 80 milligrams a day not only reduced the brain volume loss, but also slowed down worsening disability using our disability scale. And that has triggered a big phase 3 trial funded by the NHS in the United Kingdom to test this hypothesis in a larger group of patients. I personally don't think it's working by MS mechanisms. I think it's working by comorbidities, which means we as the MS community now have to start thinking is what can we do to help people with multiple sclerosis optimize their aging mechanisms. So they should exercise, and they should exercise properly. They should live healthily, good diets. We should make sure they sleep well. There's now emerging data in the dementia field that sleep deprivation or night shift work, for example, increases the risk of getting Alzheimer's disease. That probably applies to people with MS as well. Anticholinergic drugs, we use them a lot in multiple sclerosis as symptomatic treatments to improve bladder function, for example. And they may exacerbate cognitive impairment in MS, and they may speed up aging mechanisms. So, can we do anything to reduce the exposure of our patients to anticholinergics? So there are lots of things happening in that, what I would call non-MS specific space to try and optimize MS outcomes. So the field is quite broad, and I like to think of functional, what I call the marginal gains. So the marginal gains hypothesis it comes from the sporting world. Dave Brailsford was the Team UK GB cycling coach, and he said if you could break down cycling into all its components and improve everything by 1 or 2%, it has enormous differences in terms of overall outcome. And he was right. Britain went from being also-rans to being the top cycling nation by marginal gains. And I think the same thing should apply to MS. It's not just about focal inflammatory lesions. It's about optimizing everything about the brain health of an individual with MS to maximize outcomes. And we shouldn't forget rehabilitation. So we as a community in the MS specialty have to start learning or bringing in lessons learned from other areas so we can optimize disease outcomes. And so this is part of our brain health initiative. I call it Brain Health Time Matters in MS. It's a policy document that we put together about 4 years ago to try and stimulate the MS community to think more actively about the management of MS and more broadly to cover all these aspects of brain health. And so I think, over the next decade or so, we're going to see a lot of activity in terms of research around these issues as add-on treatments or add-on treatment strategies to maximize people with multiple sclerosis.